thank you very much for this invitation. Thank you very much, the speakers, for this valuable insight. Unfortunately, the ICRC building that was bombed by the Israelis in the south, in Mawasi, was the one the previous speaker was referring to as providing prosthetics.
No.
So prior to the war, there were 2,000 conflict or war-related amputees in Gaza, a third of whom had been amputees in Gaza, a third of whom had been injured as children in the previous wars and then had grown, and then an extra 182 remained in the pediatric age range. The service was divided between Hamad Rehabilitation Hospital, which took over the pediatric work, and then the municipality provided the adult work. ICRC has been trying very hard to create a database within Gaza and has had very mixed response. 2,800 have registered, 20% of whom are children, and they're trying to create that database. Now, my job is to really talk about the surgical aspects of amputations and amputation care. So as you all know, particularly lower limb amputations can happen at multiple levels, but are generally divided into a below knee, a through knee, and an above knee, and then hip disarticulation, or what the British call the Sims amputation, which is when only the heel is preserved. And that has intrinsic problems of instability in itself. But one of the most important things is a paper that was done by MSF in their limb salvage unit in Jabalia in Al-Auda Hospital 3 years after the marches of return, which found that 40% of amputees with prosthetics were not wearing their prostheses. And the problems ranged from skin ulceration to chronic pain, to the bone overgrowing and sticking into the skin, to phantom pain, to contralateral hip pain. And neuromas. Neuromas are when one of the nerves grows and then attaches itself to the skin, and so the patient feels like an electric shock whenever that area is touched. And so based on that, we really had the first experience on how critical it is to approach a clinic, to set up a multidisciplinary clinic for the amputation patients. And so my colleagues, Dr. Mahmoud Matar, and who's an orthopedic surgeon, and Dr. Hafiz Abu Khusa set up a clinic with Hamad and MSF, and they would see these patients, and therefore very early, and deal with whatever surgical issues that arose. And a lot of the cases that were discussed really need the input of a reconstructive surgeon, because there's so much now that we can intervene to maintain lengths, to increase padding in terms of surgical procedures, to improve the quality of the stump so that these problems can be overcome. And so what we're facing in Gaza is really two issues, other than the ongoing genocide. But if you want to envisage what the prosthetic service in Gaza would look like, you have the issue of scale, which is the previously unseen number of patients who need the service, amputees who need the service. The world's biggest ever cohort of pediatrics, which is a separate field. Pediatric amputations are different. They're not small adults. Children are not small adults, and pediatric amputees are not small adult amputees. And so so when we need to envisage it, we need to highlight what the issues that need to be seen and discussed. One is, as my previous colleague said, we need to now start looking to raising money to sending people for a degree in prosthetics. The number of prosthetists in Gaza is nowhere near what is going to be needed to service people. Two, you need to set up the workshops that do the adjustment, as my colleague said, that are able to deal and provide the kind of work and on the scale that we need to. We need to create rehabilitation, both on the outreach in primary care and within the center itself. And we need to try to build as much of the prosthetics inside Gaza, because the sheer quantities of prosthetics that Gaza will need for the generation after this war ends means that it cannot afford to import prosthetics. And there are lots of universities like Imperial College who have labs who are working on designs of improving designs in prosthetics that need to be brought in to this kind of discussion. The other thing that I think, especially with regards to the pediatric group, but also to the adult group, is the damage long-term that wearing a prosthesis causes on the other unaffected limb. And so particularly if it's an ill-fitting, or as in the case of the children, if it hasn't been changed to keep up with their growth spurt, children have back deformities and they develop osteoarthritis and in the contralateral hip and the contralateral knee. In addition to the fact that with age, pressure leads to atrophy of the fat and the muscles, and therefore the quality of the stump begins to deteriorate. So all of this, these issues require an ongoing, continuous, multidisciplinary, holistic service that brings prosthetics, orthotics, surgery, rehabilitation, psychosocial support into a single multidisciplinary service that looks after these patients in a continuum, in a lifelong journey, to ensure that they remain active and remain able to resume schooling, resume work as much as they can. And eventually, we need to look at the evidence of the aging amputee. And there is evidence from the United States, from the veterans database, that after 65, 2/3 of below-knee amputees are wheelchair bound because of the damage to the other knee, because of the damage to the other hip, because of the atrophy of the stump and the skin of the stump with the aging process. And so one of the things that we're hoping to arrange in Lebanon, hopefully sometime in the early summer, is to create a workshop where we bring everyone who's involved in this continuum, from the academics to the funders, to the prosthetists, to the surgical humanitarian organizations, so that we can have a single roundtable discussion about how we envisage this process to be set up, including a cloud-based database that is able to keep track of these patients who are in Doha or in Egypt or in Beirut, and will eventually, hopefully, be going back to Gaza at some stage, so that their notes and their services are, there's continuity of care. So there's a lot of challenge. Gaza is amputation catastrophe is unprecedented, and therefore we need to bring all of the stakeholders together. And the problem is NGOs have a horrible habit of working in silos, of believing that they are single-handedly changing the world, and therefore all of these services need to be brought into Palestinian control, Palestinian leadership, for the service of Palestinians. And these NGOs need to decide whether they want to be serving the Palestinian people or they want to be serving their funders, and need to be brought into a single unified process. So I will leave things here. And
I have
thank
one
you
more
again
question, Dr. Iza,
yes,
if you...
go ahead.
Yeah, sorry. As you have ground experience in Gaza and what was going on and what is going on as well, in your experience, are the blast injuries seen in Gaza and as an effect of the genocide, are they different from other common injuries sustained in other wars? And does the occupation military force sponsors strategy of maiming to create a disabled society?
So we saw in the marches of return between 2018 and 2020 that there was an intentional targeting by Israeli snipers of the lower part of the thigh so that they can catch the artery and the nerve. So what they used to call in Northern Ireland kneecapping, where you shoot one bullet and you try to catch the artery, the nerve, and the knee joint at the same time. The destruction of the health system in Gaza means that a lot of so my colleague, Dr. Mohammed Abeid, who's currently imprisoned by the Israelis, towards the end of 2024, towards the middle of 2024, was telling me that a third of the amputations he was doing in Jabalia in the north were previously salvageable limbs that could not get their reconstruction done early enough and turned into osteomyelitis and ultimately unsalvageable. And even as early as when I was there, some of the patients, because we had so many cases, we could not take to the OR to clean early enough and debride early enough, became infected. And so what you could have reconstructed now needs to have an amputation to save the patient's life from sepsis.